So any child that's got craniofacial developmental abnormalities, Treacher Collins, Crouzons, for example, any of those craniosynostoses where there's an impact on eustachian tube function, they're an at-risk child. They may not behave by the normal rules of engagement, and usually these children already have an ENT, but if not, that might be something to be a little bit more vigilant about in terms of just getting an ENT just to look over things sooner rather than later, so that if there is going to be a period of observation and during that end of observation there's no resolution, there's intervention ready to go, rather than waiting the 3 months and then waiting the couple of weeks or whatever it takes to get in to see the ENT, and then just adding to the delay. They've already got their foot in the door. Certainly any child with a cochlear implant. I think if a child has a cochlear implant and they've got middle ear fluid, that's something that you should be liaising with their treating ENT team, just to clarify what they think with respect to that fluid and what could or should be done about it. Because it is a concern when you've got a foreign body and an infection around that foreign body, and cochlear implant fits that bill. So that would be another reason, again, just to maybe be a little bit more proactive in engaging with the ENT sooner rather than later. Another one is Down syndrome. Down syndrome, again, high-risk patient from an ENT perspective for all sorts of reasons, ears in particular. So from that point of view, again, they can be hard to assess as well if they have the narrow ear canals as part of their presentation. So again, defer to ENT earlier in that situation would not be inappropriate. Again, if they have an immune deficiency, you may want to be looking at getting ENT interactions as part of the team management again. It may be that nothing warrants intervention, but there's no harm in having that confirmed. So again, I think team effort is always a good way to go. Children with cleft palates, either present or that have been repaired, are high-risk patients as well. So you need to be mindful again that they may not sort themselves out properly. Any child that's already got a pre-existing hearing loss for some other reason. If the fluid's there and it makes them deaf, but they were deaf to start with, and it makes them even more deaf, they may venture into territory where their hearing loss is actually quite significant for them. So again, taking patient considerations into account. And another one which may sound obvious and so forth in terms of what I'm stating, but if they're blind,